Well, good afternoon, everybody. This is Jake Galdo, PQA's Director of Education and Program Development, and welcome to our Quality Forum this month. We'll be doing telehealth, advancing care during pandemics and beyond. We're very excited to have Adam Chesler from Cardinal Health joining us today. As always, just a few logistics at the very beginning of our presentation. Send us your questions in the questions feature. So that way, at the very end, we can kind of ask some of those questions to Adam and have a good dialogue about what's going on. Today's forum is being recorded, and a copy of the slides and audio recording will be housed and shared within PQA members within about a week. And at the end of today's presentation, we'll have an exciting announcement of where it's going to be housed for the future. And then, as always, when you're done with the webinar, there'll be a quick prompt to give us feedback. So please give us that feedback so we can continue and improve our educational offerings for you. Please note that we have our next quality forum. It's going to be Monday, May 4th, so it's Star Wars Day. I didn't do that intentionally, but I'm very excited by that either way. It is a little bit different from our traditional Thursday quality forums. However, it was the time that could align with our presenters. And so our May quality forum is, again, going to be Monday, May 4th at 12 o'clock Eastern. And it's going to be a continuation of our conversation today. So we have Adam that's going to be sharing the regulatory and community pharmacy perspective. And then we're going to be shifting over in May to learning about telehealth best practices with two of our Blue Cross and Blue Shield PQA members, one from Alabama and one from North Carolina. And so today's presenter is Adam Chesler. He's a PharmD MBA. He's currently the Director of Regulatory Affairs at Cardinal Health. Essentially, if you Google telepharmacy, his name pops up. So we are extremely excited and lucky for Adam to be sharing his perspective, expertise, and knowledge in this area. He gave me a really nice bio about himself that I'm going completely off script just because I'm really excited for him to be here. And I just want to really highlight the fact of, again, he is a thought leader in this area of telepharmacy, and so I think he's got a lot of really cool things to share, and it's very timely in our COVID-19 pandemic world. So with that off-the-cuff intro, Adam, the floor is yours.
Thanks. Appreciate it, Jake. Appreciate you all for dialing in. Quick, brief agenda. It's always fun to summarize. I'm going to be talking a little bit about telehealth, and most of these are new slides, so if you guys have feedback on them, we put them together just for you. Quick overview on telehealth, what's been going on with telehealth. I'm going to go into telepharmacy. When I say telepharmacy, it often means multiple different things to multiple different people. So I'll kind of explain that a little bit, talk about the current regulatory landscape and how that's changing, discuss some advocacy efforts and how you can help with advocacy, or if you're interested in advocacy, future implications of telehealth, and then we'll open it up for Q&A. To start it off, just a brief history of telehealth. I don't like reading slides to people. I'll just highlight some main points in here. I thought it was interesting back in 1879, the Lancet was talking about, well, number one, I thought it was interesting the Lancet magazine was around back then, but it was also interesting that they were describing using a telephone to reduce office visits to expand access to a provider and access to care. And that was back in 1879, 100 years before even I was born. Kind of rolling into the 1920s as well, a little interesting tidbit of that. There was a Science and Invention magazine. They talked about the teledactyl. It was an invention with a robot fingers and a radio technology, and they could use it to examine patients from afar. They've been talking about telehealth a really long time. Radiology started in the 1940s. And you can kind of see the U.S. government, kind of a common theme with the U.S. government in the 1970s. They started getting involved in telehealth as they saw it a great way to improve access to providers. Our government may not be the fastest at everything, but their embracing of access to care has been great, and you'll see that in telepharmacy as well. And nowadays, telehealth is everywhere. You're seeing it all over the news, seeing it all over TV. There's auto transcription of medical records, smart devices, direct-to-care health. It's really expanding significantly. And how telehealth is being used is varied quite wildly as well. The technology is, most people are using store and forward technology or asynchronous store and forward, which is where they're taking images or using live video, sending it to a provider. The provider's reviewing those images and providing their feedback. That live video in there as well, and as well as remote patient monitoring. Telehealth started as primary care, that idea that we're just going to have access to one patient, but it's expanding significantly into specialty care now, especially with the COVID-19 crisis. My sister is a dermatologist in Miami Beach, and she's doing teledermatology now. Everybody I'm talking to is doing some sort of tele something, dermatology, cardiology, radiology. You're even seeing telesurgery at this point, where surgeons, you could have the top surgeon in the world performing the surgery remotely through robots, through telehealth. Direct to consumer as well as picking up. We're seeing a lot of these newer technologies coming into the market where they're providing access directly to the patient. They're doing a telehealth consultation and then providing those services direct to the patient. Have some of those names on the right, Roe, Rory, Hims, Hers. And then there's a little list down there of other healthcare professionals that use telehealth. This is only a partial list. It's quite an extensive list of people who are using telehealth. I thought it was kind of interesting. They have telemidwives is probably the proper language, televeterinary medicine. Telehealth is here. It's not going away. It's only going to be continuing to grow. You can kind of see that with this chart. I just wanted to compare telehealth before COVID and telehealth after COVID. If you look at the light blue dots, that was telehealth pre-COVID. Most of the telehealth was being used for mental health conditions, depression, anxiety, a lot of telepsychiatry. Since COVID, you can see that shift with the darker dots on there. It's really shifting into the chronic care as well. We're seeing a lot of telehealth being used for hypertension, cough, allergic reactions, chronic pain, continuing to expand and grow in areas that it wasn't really expanding in before. And the surge in telehealth, you hear a lot about it, but these charts are kind of showing the reality of it, the baseline. Look at March 6th, a little bit over baseline. Telehealth was growing, it was increasing, but it wasn't increasing exponentially. And then all of a sudden, it just exploded. There's overall telehealth claims are up 1,000% from baseline. Patients that are new to telehealth, there's almost up 3,700%. More patients are using telehealth. And that's really creating that paradigm shift where people are learning how to use this technology. They're getting familiar with the technology. The technology really is the only option. And you see a lot of that in crisis and pandemics. People come out of these things with complete paradigm shifts of how they do things. And this is going to be one of the largest shifts, we believe, in healthcare moving forward. Once people are familiar with the technology, they're forced to use it, and they become comfortable with it, they're going to be able to use it from that point moving forward. And how much healthcare is going to change is going to be an interesting subject to watch. So we talk about telehealth for all these other providers. Let's kind of dive into telepharmacy. There's 4 main types of telepharmacy. We like to break it down into remote order entry review, which is where you the order is entered. A lot of hospitals are doing this today, and then a pharmacist at a remote site is reviewing that order to make sure that it's entered correctly, it's clinically significant for the patient, the dose is correct, et cetera. We're seeing telepharmacy being used for IV admixture now. Think about every time a IV bag is made, a pharmacist has to garb up. It's got to be sterile. They have to walk in the room, check the bag, garb down. Especially right now with the shortage of PPE, people are using telehealth or telepharmacy to oversee that IV admixture. And you can actually take little videos of the drug being drawn up and injected into a sterile bag. There's going to be a study coming out of UNC that shows telepharmacy is being used in IV admixture at a safer rate than it is in a traditional pharmacy with less errors. So keep an eye out for that one. Outpatient is a retail telepharmacy. We see that that's kind of the commonly understood word of telepharmacy. That's the brick and mortar site, remote oversight by a pharmacist overseeing a pharmacy technician. The technician is on site. Scope of practice remains the same. Everything a pharmacy has done remains the same. Everything a pharmacist has to do stays the same. The only difference is we're saying you can supervise a technician remotely. You don't have to be standing next to somebody to see and hear everything they're doing. And that as well is being shown. A couple studies coming out that it may be even safer because you have all that camera access and you can see and hear everything, and you can even go back and check up on things. And then remote counseling, as pharmacists are continuing to get paid, reimbursed for their services, we're seeing an increase in remote counseling, access to pharmacist care services, especially during this crisis when a pharmacist may be the only healthcare provider available for patients. So let's focus a little bit on retail telepharmacy, since that's the most widely accepted form of telepharmacy or understood name of telepharmacy. I have a picture here of an actual example of a retail telepharmacy. This is in Story, Iowa. A real interesting story. There was a physician's assistant out there and thriving business. They had a brick and mortar pharmacy next door. Unfortunately, that pharmacy had to close. They didn't have enough business. They weren't able to keep a pharmacist on staff. They closed the facility, and the PA at the clinic on the left there started losing business as well. She started to notice that patients were driving out of town. They were going to the local big box that was 15, 20 miles out of town. And they figure, well, if I have to drive all the way out there, I'm going to go see the doctor out there too. I'll do my grocery shopping out there. Continued shuttering of businesses in that town. The company came in and put a telepharmacy in that same site that the pharmacy was in there before. And all of a sudden her business started to ramp back up. So she ended up having to let go of PA because her business was down, and then she had to rehire them once the telepharmacy was back. And I always like this story of the telepharmacy is because she has a tablet in her office, And they have a great connection with the pharmacy next door. And anytime she has a patient who may have issues with the therapy, maybe they failed a statin therapy, she will call the pharmacist on the tablet, press the button, bring the pharmacist into the room, and they all have a conversation about the therapy and determine what the next course of therapy should be for that patient. Really is what we went to school, or at least pharmacists went to school and were told this is what pharmacy is going to be. This is how the continuum of care is going to go. Your value is really going to be seen. And to me, I love that story because it's actually what I think how I think pharmacy should be practiced. But pharmacists are overseeing that facility at all times remotely through audiovisual technology. And telepharmacy isn't a new concept. I'll go in more to the workflow of telepharmacy in a little bit, but just some background of telepharmacy again. Telepharmacy dates back to the 1940s, almost 80 years ago. The Australia's Royal Flying Doctor Service. I could probably talk for an hour just about that because it's super interesting what they were doing. If anyone's familiar with Australia geography, 80% of the population lives in 20% of the country, which is just on the borders. It became quite evident during all the fires that were going on recently. But you now have 80% of the landmass with 20% of the population. It's a huge area with not very many people. I even remember seeing a map of one road was closed for the fires and the person had to take a 5-hour detour to get to where they were going and it was normally only 15 minutes away because it was the only road in town. We'll time warp there up to 2001, which is when telepharmacy really came to the United States. That's where North Dakota was the first state to allow it. They did a study in 2002. There was the North Dakota State University study, which showed telepharmacy can be performed as safely, if not safer, than traditional pharmacy. And I like to highlight that one because in 2002, the technology is nowhere where it is today. Think about, I think the first iPad even came out a couple years after that. Broadband has gotten better. You can basically FaceTime anyone anywhere nowadays. There's software that can recognize the imprint of a tablet and tell you exactly what tablet it is in the fraction of a second. So if telepharmacy was performed safely back in 2002, I'm pretty sure with the advances of technology today, it could be performed safer. And then kind of highlighting the U.S. government again, in 2006, the U.S. Navy started using telepharmacy. Think about all their ships that are out at sea, and they need access to a pharmacist in all these facilities, and they started really utilizing telepharmacy to do that. So why does telepharmacy matter? Why do we need this expanded access to care? Number of independent rural pharmacies, as we were talking about that one in Iowa, is decreasing significantly. There was a 16.1% decrease from 2003 to 2018. 1,231 independent pharmacies closed during that time. It's really hurting rural access. There's 64 million Americans living in rural areas across the U.S. and 1.7 million Americans living in what we call rural pharmacy deserts. That's 10 or more miles from the closest pharmacy. These are patients that are having difficulty getting access to their medication. If you can imagine, anytime you needed to get any kind of prescription, you'd have to drive 10 miles to it. Even if you saw your provider and you were sick that day, you'd have to go 10 miles each way, no matter what the weather is. It becomes quite a hardship, at least 10 miles. And that was really where telepharmacy started, was how do we create access points for rural areas? What we're seeing is a understanding that telepharmacy is useful in urban areas as well. There's major medically underserved areas, even in cities. Lots of patients that don't have vehicle transportation. They have to rely on public transportation. They may take 2 buses every time they need to go get their prescriptions filled. Senior citizens who may have access or mobility issues, patients who are in wheelchairs. I've even heard stories of students on campus where students don't have vehicles. And if there's no pharmacy on campus, it's a hardship for them to get access to their prescriptions. And we're really seeing telepharmacy expand that access to a pharmacist, since it preserves the scope of practice, since everything a pharmacist has to do in a traditional pharmacy, they have to do in a telepharmacy. It's expanding that reach of the pharmacist to be able to take care of more patients in more places. A couple of numbers related to this. If you look at Chicago, there's about 32% or 1 million residents who are living in what's considered an urban pharmacy desert. And they're having major issues getting access to care, and that's considered 1 or more miles to an access of care. I don't know if I'd want to walk a mile in the middle of the winter in Chicago, but there's residents who we've interviewed and they're doing it. So telepharmacy is really helping improve that access for these patients. There's a couple of benefits of telepharmacy. It helps you share and maximize resources across locations. You can combat declining reimbursements. A lot of these pharmacies are closing just because they're not making enough money, but you could potentially open a telepharmacy and have access to a pharmacist that will be able to increase some of that, provide access to patients in underserved areas, offer convenient dispensing of point of care. And then the one we wanted to highlight in this presentation, just because it's relevant to these pandemics, is promote social distancing. We're seeing the situation we have right now is there's a pharmacy with a pharmacist on site, and we're doing consultations with patients. And I wrote a couple blogs on this because it just kind of shocked me when you think about it. We're talking about social distancing and how you have to be 6 feet from anybody, but it's really hard to have a private face-to-face consultation with a patient. And that face-to-face thing always comes up because there's HIPAA requirements. You want to make sure everybody's information is confidential. But if you're doing that, you're exposing basically yourself and everybody else in that facility. And when something like COVID, where you don't know if a patient has it and you can be asymptomatic, a pharmacist could be spreading this to patients, and a patient could be spreading it to a pharmacist and pharmacist staff. So we're seeing a lot, and that's that increase in telehealth. There's a huge spike in use of telepharmacy right now because it's providing that social distancing. And I'm going to go through all the changes and how it's being used. But if you have that face-to-face consultation through a tablet, you can still see and hear the patient. You just don't have that risk of transmission. Walk you a little bit through the retail telepharmacy workflow since I'm talking about telepharmacy. A patient would walk into a pharmacy, they drop off the prescription. A technician enters all this data into the computer just like they do today. A pharmacist reviews that data remotely, and we call that PV1, and we'll come back to that later. It's Pharmacist Verification 1. The pharmacist reviews that information that's entered. They can see the technician enter the data. They can see the patient come into the store. The technician then fills the prescription. If the pharmacist approves it, make sure it's clinically significant. The pharmacist can see the technician filling it. They verify the images of the fill to make sure it's filled correctly. I've also mentioned there's software out there that can verify those tablets automatically and count them with 100% accurate. I'd say 99.999% accuracy within a fraction of a second. But then the pharmacist reviews that fill just like they do today. And then before the patient can go home, they have a face-to-face consultation with the pharmacist on a tablet. Then the technician can ring them up and allow them to go home with their prescription. So it works exactly like a traditional pharmacy. You just separate everything the pharmacist does, and they do it remotely. One of my favorite parts of my role is thinking about how you can use telepharmacy, and there's infinite use cases really. What I always think of telepharmacy as is anywhere you've ever said, man, it'd be great to have a pharmacist there, telepharmacy allows you to. Community pharmacy, rural or urban, especially in underserved areas, outpatient hospitals and health system pharmacies, so they can discharge the patient with that first fill so patients aren't getting readmitted for not taking the medication. CHCs, federally qualified health centers, these are patients who need specific pricing on their medications and they have difficulty affording it otherwise. This is a great way to get them started on it. We're seeing specialty pharmacies. This will give you that especially HIV centers of excellence are using this, so you can have that residency trained pharmacist giving a consultation on the HIV medication, get the patient to start their therapy sooner and get them to actually start the therapy at all before continuous viral mutation can happen. Mental health centers is booming with telepharmacy. You look at the patients in a mental health center, they're 50% compliant to their medication if there's no access to a pharmacist on site. If you can give them access to a pharmacist on site, they're 90% compliant to their medication. And it's quite a population where if they're not taking their medication, they're going to end up right back in the mental health center. So they're really embracing access to a pharmacist care through telepharmacy at these mental health centers. Employer campuses and schools, physicians' offices. I often mention this we hear a lot about physician dispensing. Physicians are trying to dispense medications because they want their patients to be adherent to their medication. They're getting judged on patient outcomes. No provider or no physician I know wants to do this. They do it because they want their patients to have their medication. I'm not going to say there's not a physician out there who doesn't want to do it, but the majority of them do not want this burden. We have tons of regulations and laws in place they don't want to have to worry about following. They just want their patients to have access to care. The problem is physician dispensing doesn't have a pharmacist in the workflow, and the pharmacists are the medication experts. So we're seeing physician offices embracing telepharmacy to have that pharmacist on site, that point of care on site, so they can confirm that their patients are getting their medication, going home with their medication, and really helping bridge that gap. Emergency preparedness as well. We're going to go into a lot more detail about that in here, but telepharmacy, you think about these convention centers that they're converting to hospitals, parking lots that they're converting to hospitals, they need access to medication. Telepharmacy allows you to set up a pharmacy anywhere you need one. All the requirements are still in place, but you just don't have to send that pharmacist out there. The pharmacist can supervise it remotely. We've seen this being demonstrated during crises such as hurricanes, where they have mobile pharmacies, et cetera. So it's being used significantly for emergency preparedness. We'll talk about the regulatory landscape now. So everybody hears all this, and I can talk about telepharmacy all day, and people say, this is great, I want to do it. I can think of numerous places that I'd love to have access to a pharmacist. I I, as a pharmacist, want to take care of patients in all these areas. Where can I do it? So it's pretty widespread today. Not all states embrace it, and this map may be a little misleading because while there are 24 states that permit retail telepharmacy, they vary quite significantly. I can go through each state if you guys have any questions on specific state regulations. I probably know them all, but it would vary wildly. You look at a state like Illinois or Idaho, there's zero restrictions. You can basically open a telepharmacy anywhere you think as a pharmacist you want to improve access to pharmacist care. And then you look at a state like Nevada and you have to be 50 miles, 50, from the closest pharmacy in order to open a telepharmacy. Which you hear that and you'd say, man, that's insane. There's actually an operating telepharmacy in Nevada that is 50 miles from the closest pharmacy. There were patients who had to drive 50 miles each way just to get their medications in Nevada. If you don't think they're going to embrace mail order or any other way to get their medication, that's it was definitely difficult for them. And then I mentioned Illinois. There's over 200 telepharmacies nationwide. Illinois, there's almost 100 of them operating in Illinois today. Illinois has had telepharmacy laws on the books since about 2012, actually 2007, sorry. And there's over 100 operating today, and you don't really hear too much about it. I don't think Illinois gets as much credit as North Dakota does for being the hub for telepharmacy, but there's a lot of telepharmacies in operation today if anybody ever wanted to visit one in urban and rural settings. There's numerous telepharmacies in the south side of Chicago as well as in the rural areas of Illinois. And I mentioned those regulatory considerations and how they vary wildly across the board. Figure I'd cover a couple of the top ones we've seen. Pharmacy technician certification and hours of experience is one of the biggest ones you see. Does the pharmacy tech have to be certified? Is there a certain number of hours of practice that they've had to have done already to work in these facilities? Or is it up to the pharmacist's judgment? Every state really varies on how they feel about that. Some states say a pharmacist can put whatever technician they want in these facilities because they are the ones ultimately responsible. And other states have that higher level of mandated requirements for those techs. Special rules around controls. There's a couple states that don't allow C2s. There's a couple states that require a pharmacist to be on site to check in the C2s. There are some states that there's a little bit of problems with that. PBMs, for instance, will say you're required to provide all medications to the patient or else you won't get a contract. So in the states that don't allow C2 medications, they may not be able to get a PBM contract. There's also rules around, do they have perpetual inventories? Almost every telepharmacy, actually every state that allows telepharmacy requires a perpetual inventory on controlled substances that is reconciled at least once a month, where the pharmacist has to go on site and count all those tablets to make sure they're reconciled once a month instead of the twice a year or once a year that a lot of annual controlled substances are. Limits on the number of remote site or technicians. How many, does it abide by your state's ratio? So you're still supervising the technician remotely. Is it the same as your state's ratio? Is it lower than your state's ratio? If your state doesn't have a ratio, are they imposing a ratio on the technicians? Every state is looking at that a little bit differently. Security requirements. The big one with the security requirements, and this is the fun of law, is the argument over how many days of storage you have to keep. Do you need to keep 30 days of video storage? No state allows you or requires you to videotape the consultation. They do require you to have the initials of the pharmacist who does it so it can come back up, but videotaping a consultation could be a fear of a HIPAA issue if that videotape ever leaked, but they do require you to videotape the facility and be able to look back at that when the pharmacist is actually on site. If they notice any discrepancies, they can go back and check it. So there's tons of requirements over how many days you have to record that for. Is it 30? Is it 45? Is it 60? Is it 90? Almost as many discussions about that as the exact wording for the sign on the door that says this is a remotely overseen site, or this is a telepharmacy, or you get where I'm going. Mileage restrictions. A lot of states have a mileage restriction, which is also an interesting topic. If it's, in my opinion, if it's safe to practice this way at 10 miles, and when I say 10 miles, they'll say a telepharmacy has to be 10 miles from the closest pharmacy in order to open. So if there's any pharmacy within a 10-mile radius, you can't open a telepharmacy, whereas other states say you can open a telepharmacy anywhere. As I mentioned, Illinois and Idaho, Arizona is another one of those. So if it's safe at 10 miles, why isn't it safe at 0 miles? That's a whole nother discussion, but a lot of states are putting these mileage restrictions in there saying you can only open one of these X number of miles from a traditional pharmacy. I think the key there is to preserve the requirements that the pharmacist has to do in these facilities. So it is the same level of care. And then technology requirements. I won't bore you with technological data, but there's a lot of rules around what kind of security they have to have, HIPAA compliant software, things to that extent. We put together a little summary of state retail telepharmacy regulations. There's a couple states that are considered progressive. They're the ones that are really allowing pharmacists to expand their scope, kind of leaving it up to the pharmacist, saying if there's anywhere you want to provide care to a patient, go for it. There's a couple that are moderate. They're putting a little bit more restrictions in there, and then we separate them as restricted, not allowed. I like charts. I have lots and lots of charts. So if you guys want charts of anything, please don't hesitate to reach out. So what's going on with telepharmacy under COVID-19 or under the pandemics? There's a couple regulatory considerations you're looking at through this, and we'll kind of break it down into the 4 steps of pharmacy or of telepharmacy. So we mentioned PV1 before, that's that remote order entry. So there's some COVID regulatory considerations on PV1 telepharmacy, PV2, which is that pharmacist verification 2, the product verification. Some states are looking at that. The remote consultation, that face-to-face consultation that the pharmacist is having with the patient. Some states are waiving some laws for that. And then finally, the remote supervision, which is a pharmacy without a pharmacist on site, so the pharmacist can oversee that facility remotely. So every state is looking at these. Jessica Adams on my team is basically going through every one of these emergency declarations daily and compiling them into a spreadsheet. If anyone wants any of that access, definitely reach out, and I'm sure she'd be happy to share it with you. Even the data in this presentation that I'm going through, I just need to throw out as a caveat, make sure you're double checking with your state if one of these is waived for this and this is something that you wanted to do. It's constantly changing. States are looking at this on a constant basis and updating it on a constant basis. So we always recommend you reach out to your state board. And I am not a lawyer. So we'll look at the PV1 when I was talking about that PV1 telepharmacy or remote order entry. The technicians are entering the data and a pharmacist is verifying that information remotely. It's interesting how many healthcare providers are working from home right now. You're seeing that expanded to pharmacists and pharmacy technicians through waivers for COVID for PV1 telepharmacy. The pharmacist verifies the prescription to make sure it's entered correctly. The technician enters the data correctly. The key is how do they do this safely and securely under HIPAA requirements, even though HIPAA is fairly waived for the COVID pandemic. But PV1 telepharmacy has been around for a while. This isn't really that new. A lot of states have PV1 waivers or have had PV1 waivers. So if you look at this map, most states other than Mississippi have allowed this practice. It's been around the longest. Majority of states have allowed it. And we're continuing, while some of these may be waivers, a lot of these states have allowed it forever. And a lot of states are moving that direction as well. Looking at PV2 telepharmacy, again, that's that product verification. The technician is filling the prescription, taking pictures of the tablets, imaging their process, or maybe videotaping it and sending that to a pharmacist at a remote location to review it to make sure it's filled correctly. All the work is performed by a technician under supervision of a pharmacist. Usually it involves barcode scanning and visual confirmation, if not a computerized confirmation of the tablet. Excuse me. Looking at the next state, this is just a sample of states that are doing the PV2 waivers. They're allowing the pharmacist to remotely review these prescriptions. Again, this is definitely reach out to your state board for verification and additional details, but this is just a couple states, Iowa, Minnesota, Missouri, New Jersey, that have waivers in place that are allowing a pharmacist to do that PV2 verification remotely for COVID. It's about 30 minutes when I need to have a drink of water before my throat starts going. Give me 1 second.
Go for it.
Thanks. Remote consultation, that's the face-to-face consultation the pharmacist has to have with a patient. Again, this is also the time that the pharmacist is most exposed to a patient. They're having that face-to-face consultation. There can be a transmission. If a patient is sick, most patients get triaged at pharmacies. I know when I was practicing, a lot of patients would always come in and show me something and say, what is this? All my friends that I'm talking to who are working in pharmacies now are telling me how patients are coming in saying, hey, I have a dry cough and a fever. What should I be doing? Patients are looking to their pharmacists for access to care because they aren't able to get their providers on the phone right now. That remote consultation, even if that is just answering that question, protects the pharmacist and protects all those other patients that are in the store. And that's communication by the pharmacist, ensuring proper use of these medications or devices. That remote consultation is being expanded medication therapy management services. Even for home monitoring services, you're able to do a remote consultation with the patient to make sure they're taking their medication properly. That one's pretty simple. Again, here's a sample of states that are allowing remote consultation. Again, contact your applicable state board if you want additional details, but looking at California, Arizona, Colorado, Texas, Louisiana, West Virginia, New York, they're all allowing some form of remote consultation right now. Language may vary between the states, and even between putting these slides together a couple days ago and today, this may have changed significantly. Remote supervision, that's the remote pharmacist overseeing a pharmacy. So a pharmacist without a pharmacist on site, the pharmacist is remotely overseeing that pharmacy. This one has become prevalent pretty recently as well, because we're seeing a lot of pharmacists who are getting ill, and they're having to close their pharmacy, which is making access to care even harder for patients. So we have pharmacies closed. I had somebody call me the other day out in Texas with 8 pharmacies, and too many of their patients got sick, so they closed all their pharmacies. So, and these are 8 rural towns all through Texas, and I live in Dallas. So it was not in Dallas, it was outside of Dallas, and now we have all these towns where patients don't have access to care. It's continuing to happen. Patients are continuing to be ill, pharmacists, technicians, and every closed pharmacy is reducing access to care for patients. So states are allowing remote supervision to allow the pharmacist to oversee that facility. A pharmacy can operate without a pharmacist physically present. They do have to be on site. The pharmacy cannot open or close without a pharmacist remotely present. So that's the only change there, is the pharmacist has to be overseeing the facility remotely. Nobody can go in unless a pharmacist is overseeing it that way. Again, states with sample remote supervision, Idaho, North Dakota, Arizona, a lot of these have allowed this for a while. South Dakota, Missouri, Illinois, Michigan, Michigan is probably, might be the most recent. I think there was another one since then, but states are looking at ways to provide access to pharmacist care and continue to expand that access. Use cases during COVID, I think I mentioned some of these. Every other healthcare professional is working from the safety and comfort of their own home without fear of getting ill. This is allowing pharmacists that same ability as well. This is a crisis. Patients need access to care, and pharmacists have always made themselves available, and I'm sure they always will continue to, and this is continuing that access. Workload balancing across locations. So if you have one area that's in a hot spot that's just exploding, I saw the other day that I think they're paying nurses $10,000 a week to go out into New York because it's such a hot center right now. You could use telepharmacy to help balance some of that workload. If you have a pharmacy that's getting just overwhelmed, you'd be able to help them out through telepharmacy. Sick coverage, we clearly don't want anyone going to work or going near work if they're starting to feel ill, whether it's COVID or not, any kind of illness. I think this kind of raises the awareness of people taking sick time when they need sick time. And you could use telepharmacy to help with that. After hours care, I feel like I said this a lot because there's a lot of hot topics right now, but this was another hot topic. How do we extend stores' hours? How do we give them 24-hour coverage when the volume isn't there? You could use telepharmacy to have one pharmacist overseeing 4 facilities overnight, but there is a pharmacist on site throughout the day. So it continues to expand that access during slower times. Or patients who are going to urgent care centers and getting discharged, they can now have access to a pharmacist at that urgent care center as well. Preventing store closures for COVID, that's a big deal. We want to continue to keep our access to pharmacists open, our pharmacies open. This enables the pharmacy to be able to stay open even if someone is ill. Access out-of-state providers, you own your patient, so you should, well, you don't own them. That doesn't sound completely right, but you should be able to have access to your patient no matter where they are. Yeah, thanks. Quick setup of a mobile pharmacy. We were talking about these disaster relief areas where they're trying to pop up care areas extremely quickly in parking garages, convention centers. They're throwing tents up. They need access to pharmacy care in these areas, and they're not able to put a full-fledged pharmacy there, but why not allow access to a pharmacist remotely? And then touchless workflows. In your pharmacy, there's telepharmacies can even do the consultation through a cell phone. So the patient can walk up to the tablet, initiate a consultation without touching the screen. The technician can initiate that consultation. The audio will dial to that patient's cell phone if they're on file, so they can have a private phone call, not touching anything, no fear of spread, talk on the phone, see the pharmacist on the screen, and totally reduce that access or any kind of issues with spreading care. Summary of COVID-19 telepharmacy waivers. Again, I mentioned we like charts here. Look at a couple of states that are listed as progressive. Now I have a dry cough. Great. Really from talking. Progressive, I haven't been out of my house in 2 weeks. A couple states listed as progressive, a lot of states listed as moderate. They're improving a lot of these waivers, and a couple that are still listed as restricted or not allowed. But as mentioned, this is a daily changing topic. Definitely something to monitor and look at and see if there's ways to provide access to care. With anything, there's always challenges and roadblocks. A lot of telehealth is growing faster than people can keep up because nobody expected this 1,000% growth overnight. Broadband coverage may not be sufficient in areas. Granted, we will say anywhere you can do a FaceTime on your phone or a Google Hangout chat, you can do telepharmacy. Technology has come a really long way since then. They may not have broadband, but the 4G coverage might be even better. Reimbursement, that's always a fight with pharmacists. How do we get paid for a lot of these services? Are you going to get paid through the telehealth version of it? Even with the pharmacists approved for COVID-19 testing, now the big challenge is how are we getting paid to do that? Statutory and regulatory environment, that's always the biggest challenge or roadblock. How do we, are you even allowed to do it? A lot of states are prohibiting this action. It'd be great to move forward and do this everywhere, but there's just roadblocks and statutory and regulatory blocks. Interstate variability in language, what you may be able to do in one state, you're not able to do in another state. So some states may be providing access to care through this, and other states would allow it a little bit differently. Concerns over privacy and security. I always had to make sure privacy and security are number one, is a number one concern when performing this. There was this reluctance to use technology. I think that's changing significantly. I was actually having a discussion with my father the other day. He didn't want to go to the pharmacy to get his prescription, so he had his pharmacy deliver it to him. And he said to me, "Why would I ever go to the pharmacy again? That was so easy." I was nervous to even allow that. So reluctance to use technology is becoming overcome during this crisis, and I think that's what's going to cause that big paradigm shift. Is people are forced to use it, so that reluctance is going to have to go away, and they're going to realize how easy it is to use. And then perceptions on patient interaction. You're going to see another study coming out soon showing patient interaction in a telepharmacy, and does it have the same quality outcomes as traditional care? And spoiler alert, yes, it has the same quality. Advocacy. There's been support from associations, NABP, ASHP, and APHA. Actually, before COVID, these associations have said they recognize telepharmacy as a form of pharmacy practice or care. They include it in their definition and part of their guidance in increasing access to pharmacist care. So before COVID even became an issue in the United States, or this pandemic even came through, NABP, ASHP, and APHA were all supportive of using telepharmacy. Since COVID-19, a bunch more associations have jumped in and said pharmacists can respond to address patient care needs through telehealth and telepharmacy if the appropriate authority is provided. That list also is continuing to grow as everybody's looking for access and supportive of telepharmacy. If you see a need in your state, I always recommend advocating for good policy in your state. I was never as a student, I probably wasn't the best. I was not involved in my association. I didn't understand the value of it. Now I'm the treasurer of the Texas Pharmacy Association, and I recommend everybody join their association because they're the ones pushing policy in the state. And if they're supportive of it, it really helps get things done. So I always recommend advocating for good policy in your state. Just a offer out here where we have draft legislation and regulation. If somebody on the call was interested in something like this, we're happy to help with that. We have pilot proposals. I have study data I can share with you, lists and breakdowns of the existing regulations, what states are and not doing. Again, I mentioned we love charts. We can connect you to people who are currently doing this in the state, and we can help with letters to boards, associations, and more. Just throwing that plea out there. If you guys need any help or anybody's interested in seeing something like this or could see a use for this during a pandemic, let me know and I'm happy to help. So just to summarize, future implications, where do we see the future of telehealth, including telepharmacy? I think I've said it a couple of times. I always recommend the book, Who Moved My Cheese? Real quick read. If people on the phone haven't read it, it'd probably take you under an hour to read it, but they talk about the paradigm shift. The cheese is moving. Healthcare is moving to telehealth. The future is here. It's not going to be going back. There's going to be a huge shift towards it. There's been a reduced regulatory burden to allow this adoption federally and statewide. I think it's really demonstrating that telehealth can work at a large level. Everybody is kind of jumping on board. There's an increase in mainstream usage, improved patient access in medically underserved areas, better patient outcomes, and reduced healthcare costs through telehealth. And I just thinking through this, I think COVID-19 has really exposed how most healthcare regulations aren't ensuring that patients get the post-possible care at the lowest possible cost when and where they need it. If these regulations were allowing that, they wouldn't need to be waived to allow telehealth. They would have been that way in the first place. So I think that's getting exposed, and we're going to see a lot of change in that. And just wanted to end off with some actual headlines. Why is telehealth a big deal during the pandemic? These are actual headlines out of newspapers. Pharmacy workers are coming down with COVID-19, but they can't afford to stop working. Patients need access. How are pharmacists protecting staff? At first, pharmacists didn't have any PPE and they were still going to work. Luckily, that's changed. And even in the top left, you can see about 9,000 healthcare workers have positive coronavirus tests as of April 9th. Most were not sick enough to be hospitalized, but 27 have died. And that was 27 healthcare workers that didn't need to die. I could say anybody who's gotten COVID didn't need to die, but you will see an increase in telehealth, and things aren't going to change. And with that, I open it up to any questions. I probably talked a little fast. I am from the East Coast.
That is no worries, Adam. I'm sure we're getting lots of questions. I will say I think we had a little bit of audio difficulty with some people, and don't worry, we will have this recorded and shared. I'm trying to figure out where I put my mouse so I can open up our Q&A section. So give me one moment, Adam. I'm just quickly skimming through our questions so I can prioritize them for you. In the interim, you can drink some water because I think made you talk so fast that you didn't have a chance to drink.
Perfect.
All right. So in our first question that I want to kind of raise is, what's the typical workflow look like for telepharmacy? I know you kind of addressed it, but how is it different in terms of experience from an in-store pharmacy, probably from like that patient perspective?
So the patient's going to see almost everything the same. The patient will walk in, they will see a sign on the door that basically says this is a remotely overseen facility. They'll see the technician on site. The technician will greet them. They'll either hand them the prescription or it's been ERX'd over. The technician has entered all the data. The only difference the patient is really going to see is probably a bunch of cameras all over the facility. And then before they go home with their prescription, they can go up to a tablet, and it can either be automatically activated touchless from the technician with that consultation on their cell phone, or they'll just have that face-to-face consultation that they can automate anytime they walk in. They can press a button and talk to a pharmacist. The pharmacist can actually see and hear them come in. So they could even, we've had stories where they'll just message the technician and say, hey, tell Jim I said hi. The experience for the patient really isn't any different because everything is exactly the same. The only change is that supervision is done remotely.
Awesome, perfect. So a couple questions kind of looked at this, and I'll kind of spin it in a personal experience. So I currently live in Alabama, and I saw that like most things, Alabama was restrictive on every single one of your charts. However, I can say that I have experienced telehealth in Alabama where I have had a provider see me. And so can you provide any insight on maybe the regulatory differences between telehealth and telepharmacy? And the second part of that would be like, so in Alabama, it says restrictive, but as a patient, I could still consume it. Is it restrictive to deliver or restrictive to receive, or both?
Trying to think of the multiple questions there, and multiple thoughts come through my head. Sorry. It's fine. So when we mention restrictive, they're not allowing a pharmacist to practice outside of a facility. It's generally what we look at as restrictive, or there's a lot of regulations in place to prevent them from practicing outside of a facility. That's the big hurdle. So telehealth may be being used. And when you look at telehealth itself, it actually started the same way as telepharmacy started, where there were a bunch of restrictions. And here in Texas was the lawsuit that kind of changed all that. Teladoc got sued the state of Texas for being anti-competitive because they had restrictions on it. But when telehealth started, it used to be the same thing. You have to be X number of miles from your closest physician in order to get a telehealth consultation or telehealth access to care. So when we say restrictive, it's saying the pharmacist has to be on site to provide care, face-to-face, line of sight, or additional regulations in place that prevent it. Again, that's our interpretation of the rules. So our interpretation of restrictive may be different than other people's.
Perfect, thank you. Do you know if any of the major pharmacy chains are currently doing retail telepharmacy, either before COVID or now because of COVID-19?
I know everybody's looking at it. I don't know of any that are currently doing it. Kmart was doing it for a while, but select few in Illinois. There's no major ones doing it right now. And I guess it really depends on what you say by chain, because there's companies called like New Cara out of Iowa who have 10 or 12 telepharmacies. And at that size, you may be considered a large chain because they have numerous pharmacies. But I haven't seen any big ones doing it yet. The difference between telepharmacy is the one-off model. Chains can't really, at least not yet. I'm sure they're trying to figure out how to do it to provide greater access to care, or at least 24-hour access to care. But they can't change just for one store. Telepharmacy is very unique for each of these stores. Each of these use cases, as we said, has to have a specific model just for that use case. You couldn't just open a cookie cutter thing inside every single HIV facility. You'd have to build it for that specific one. And it doesn't really work at scale. So we haven't seen them adopt it yet.
Awesome, thank you. Can a telepharmacist cover more than one facility at a time, or is it just one pharmacist to one location?
That depends on state regulations as well. Every state looks at that a little bit differently. Some states say one-to-one. Some states say whatever you as a pharmacist are comfortable overseeing. It's kind of the same as saying how many prescriptions you can verify a day. A pharmacist can verify whatever they're able to verify or whatever they're comfortable verifying. They look at that. Some states look at it the same way, and some states are restricted in that sense.
Perfect. So I know that you kind of showed 4 different areas of telepharmacy, both inpatient, outpatient, but can you speak at all upon telepharmacy used in long-term care settings like nursing homes or assisted living centers, if you've seen that?
We haven't, so we've had some discussions about it. It's funny, that's the second time that's come up this week. We've had some discussions about it. People were using it potentially to verify the disbill packaging, or sorry, that was a brand name, for a compliance packaging, things to that extent to expand into long-term care. I haven't seen anybody use it yet, but my answer to that is always, if you had a long-term care facility where you don't have a pharmacist today and you'd like to have one, you could see the benefit of having a pharmacist. If they're getting the medication from a nurse or from a PA or no pharmacist involved at all, it would be great to utilize telepharmacy to get that pharmacist into that point of care. So I haven't seen it, but that's not to say it couldn't happen.
Awesome, perfect, thank you. Picking this question mostly because they're your colleague down there in Texas. They want to know if Texans are able to provide telepharmacist oversight during the pandemic, and if not, what do they need to do to set it up quickly?
So currently Texans are allowed to do the remote consultations, but a pharmacist does still have to be on site. So telepharmacy is allowed in the state of Texas. They have a 22-mile restriction. There's a whole story behind how we got the 22 miles, but 0 miles in an FQHC, 10 miles in a rural clinic, and 22 miles for a traditional pharmacy. Texas gets a little convoluted, so feel free to reach out, but they are allowing a COVID waiver right now for remote consultations. But a pharmacist does still have to be on site.
Perfect, thank you. So I'm going to do just a couple more questions, if that works with you, Adam, and then I'll shift over to our end of housekeeping items. Perfect. So this one is, if a pharmacist performs remote consultation to a patient in another state, does that pharmacist need a license to practice in the state that they conducted the remote consultation? So for specifics, dispensing is local, consultation is remote, possibly in a different state.
Yep. So I have to begin this question with saying I'm not a lawyer, so this cannot be legal advice, but generally you have to abide by the laws of where the patient is residing. So if the patient lives in another state, you'd have to abide by that law where the patient resides and where they're getting their pharmacy services.
Perfect. And so then we'll do 2 more questions. Second to last one is going into a little bit of Medicare. So because of COVID-19, Medicare has kind of allowed and expanded telehealth coverage for the first time. However, when it comes to us as pharmacists, we aren't recognized as providers. Do you know if there's any push or ability for reimbursement to pharmacists in this telehealth Medicare COVID world?
Unfortunately, right now, no. In that same letter, I think on the slide that I showed with all the associations in there, they're all fighting for that same exact thing. The APHA has been fighting for provider status for quite some time. I think they're using this platform, and NACDS and ASHP and everybody is really signing in saying, hey, you need to make pharmacists providers so they can provide this care. It's unfortunate that we were left out of that a long time ago. Hopefully they can get something changed at the federal level. I know the discussions are going on, but as of today, unfortunately, we're still excluded because we're not considered providers.
Got it. Thank you. And then our last question is, where do you think telepharmacy will be in 5 years?
Oh, I have all these great ideas. I think the landscape of pharmacy is just going to be changing completely in the next 5 years. I think pharmacists won't be involved with the pill anymore. You're going to have a telepharmacy consultation on your phone. The prescription may be completely different. And this is just me just speaking, but and it may not be 5 years, it may be longer than that. But I think you're going to have your pharmacogenomic profile. The pharmacies are going to be looking at your profile, picking medications specifically tailored to you based on your genome. They're going to be 3D printing the tablets, and they're going to be drone delivering them to your house. And you're going to have that remote consultation through telepharmacy on your phone. Everybody's going to be trying to make things more and more convenient. Access points to a pharmacist are really going to be the key there. I think this is going to be the beginning of a huge change for the point of care. Hopefully, pharmacists get more test and treatability for minor ailments, and you can actually go into the pharmacy and get those triaged and get those taken care of and pick up your prescriptions at the same time. But most everything is going to be done through telehealth, I imagine, in the next 5 years. I didn't lose you, Jake, did I?
Oh, you know what's really fun is I had myself muted as I just talked about sharing your email address to everybody. And I was like, oh, did he not like what I just did? And I was like, oh no, I'm muted. So again, everyone, Adam's email is on our screen. It's adam.chesler@Cardinal Health again. Adam, thank you so much for joining us today. Thank you for joining this webinar. It was wonderful. Got a lot of comments in real time via text messaging and other messaging saying how much they enjoyed the presentation. So thank you again for joining us. And very briefly, we just have a couple, of course. We just have a couple last minute announcements from a PQA perspective. Don't forget that our annual meeting is still happening May 13th through 15th, but it's online. So come join us online. We are still doing all the same things we would have done in Baltimore. We're going to have our poster session. We have our educational programming, and it's the same programming that our members submitted and got accepted to present. We still have our awards ceremony, and we'll also be doing 3 general sessions. So we're really excited for this online meeting, and so please attend. I would like to point out that it is free to our members, and so we really are looking at this as a great member benefit, and it's something really exciting that's coming up next month. In addition, we would like to announce, though this is a soft announcement, the launch of a PQA learning management system. So if you go to pqa.ceimpact.com, you'll have access to a variety of PQA educational opportunities, including things coming in the very, very near future. Of note, this recording will actually be saved and uploaded on that learning management system, as are our previous quality forms from 2019 and 2020, and some of our technical education webinars. And finally, we launched earlier this week a PQA blog. And our first post was done by our very own Laura Cranston, PQA and COVID-19, our commitment to you and quality. So please take a moment to check out our blog. When I wanted to get this photo for us to look at it, I literally typed in PQA blog, and it was the first thing that came up. So please take a look. We're posting what we are doing in regards to COVID and quality, but we're also updating every day with new resources, looking at a variety of issues intersecting COVID-19, PQA, and our membership. So take a moment to jump here and read about what's going on. Finally, we look forward to seeing everybody on Star Wars Day on May 4th for our next Quality Forum webinar with telehealth best practices with 2 of our Blue Cross and Blue Shield members. Adam, like I said, thank you again for joining us, and I hope everyone has a wonderful day.